Dr. Tareen, thank you for joining us on MD Newsline. Can you please introduce yourself to our audience?
Thank you for having me. My name is Dr. Hina Tareen. I'm a double board certified internal medicine and rheumatology physician. I'm happy to be here. I have my own private practice, rheumatology and autoimmune specialist, and I'm so excited to talk about rheumatology.
Wonderful. So, we're here to talk about sjogren specifically in everyday practice. And I'm so curious, in your clinic, what patterns or early symptoms make you start thinking about sjogrens?
Yeah, that's a great question. So, usually, Sjogren's, we first start thinking about it when someone presents with dry eyes or dry mouth, although there are a constellation of other symptoms that are associated with it. A lot of times, people come in referred by somebody else for significant dry eyes or dry mouth. I'm really looking at other features too, fatigue, joint pain, etc. But I'd say that's the primary reason in terms of clinical presentation that we start looking.
hmm So, as you mentioned, many of these patients present with nonspecific fatigue or dryness. What helps you distinguish clinically meaningful sjogrens from benign cases of dryness?
Yeah, that's a good question as well. I get asked that question all the time. So part of it has to be the extent of dryness. So we'll ask questions like, dry eyes. Are you having to use eye drops or artificial tears multiple times a day? For dry mouth, I'll often ask a simple question like, if I handed you a cracker right now, would you be able to chew it and swallow it without a glass of water? There are some objective testing you can do. The ophthalmologist can do it to look for how significant dry eyes or dry mouth are as well. And then the main part of Sjogren's also is the non-dryness component. So really asking and digging deep about questions about fatigue, joint pain, swollen glands, rashes, any lung or kidney involvement, those types of things.
hmm And how often do you see Sjogren's coexist with other autoimmune diseases like lupus or rheumatoid arthritis? And how does that change your approach?
Yeah, so very commonly coexisting. So we talk a lot about something called primary Sjogren's, where someone only has Sjogren's and that's it, or secondary Sjogren's, where they have it secondary to an underlying autoimmune disease. The most common secondary to conditions we'll see are rheumatoid arthritis and lupus, although we can see it in many different autoimmune diseases. And whenever we're evaluating someone with Sjogren's, we always evaluate for primary versus secondary, and then how do we approach management? So management, we address Sjogren's related symptoms. In rheumatology, we really manage conditions based on what we call manifestations or their organ disease is. So we would manage it somewhat similarly, but keeping in mind that there's also rheumatoid arthritis and lupus as a main component. We may have to address those manifestations of those diseases as well.